Well, welcome. We've had many a physician, many a surgeon on, but the rarest of all is the primary care physician. Even more rare is the old-time primary care physicians. I mean, if you're from Milford, you can trace your roots back to one of four people who brought you in the world. I mean, you can do a Cicchetti, you can do a Mastriani, you can go right down the four people that somehow brought all of Milford into being back in those days. Gone are those days where you had old-time physicians working countless hours for the passion of doing medicine. Tonight, I'm excited to introduce you to a young old physician or old-style physician. Why don't we start with an introduction?
I'm Liz Siraco. I'm the medical director for Milford Regional Physician Group, and I'm a family medicine physician who did my undergraduate training at Wellesley and my medical education at UMass, and did my family medicine residency in Barry, which is part of the UMass program. And right after graduation from residency, I came to Milford Hospital, where I had done several rotations during my training at the hospital, and loved the community and loved the feel of the hospital and everyone there. So I joined the staff, and I've been there ever since.
You say that was a while ago. I get in trouble for saying it, but didn't you get an award last night?
So last night I was honored with my 20 years of service at our annual Employee Service Awards. I was sort of in the middle of the pack. We have some employees that have been at Milford for 50 years. So there was one employee honored for 50 years, and there was another nurse that I've worked with since I've started, who was honored for 45 years of service. So it was a pretty impressive crowd.
You know, it's amazing, but I don't think the physicians understand as much as the patients do how important that is. You know, because I remember when my mother got diagnosed with intestinal cancer. Now, touch wood, that was 15 years ago.
Mm-hmm.
The compliance was so much easier. And, you know, when you make compliance easier, it's adhered to better. But for all these years, you know, twice a year, she goes back to see Dr. Mona. It's not the oncologist, it's not Dr. Cadis, but the whole time she got to drive, or we drove her, you know, 1.5 miles down the street to our hospital.
Right.
And of course, Ed and Phil have a heart attack when I call it a hospital. It's now a medical center.
It's grown.
Yeah, it's grown. I still remember the little red building that I was born in, and what it's now turned into. But it's pretty amazing, the environment that people like you, who could go anywhere, have been there for 2 decades.
Yeah. It's a family affair in my house. My husband is, he'll probably not be happy that I'm going to publicly say this, but he's an emergency physician at the hospital as well. So for us, Milford is our true home, and where we find ourselves caring for our patients and bringing our own family. And so it's, you know, an important piece. That's part of why I stepped up to be medical director when the opportunity arose, because I felt that I've always been of the mindset, and I think most of my physician colleagues, for the most part, feel the same way. We feel that if you're not part of the solution, you're part of the problem. And so stepping forward and tackling problems that arise is the way I sort of look at pretty much everything I do. And so I think that's led to success and the success of our group. Phil and I have a similar philosophy about that. And so that's how we've grown and flourished over the last, you know, he's been here 16 years and I've been here 20 years.
So he's working in the new Taj Hopkins.
Yeah.
They get mad at me when I call it that. But
yes, yes.
My darling bride had an allergy, just an allergic reaction, and I got to see the new ER. Oh my God.
Yeah, it's the poor, I mean, I think all the nurses probably lost 20 pounds because they're all running from one end to the other. It's pretty big, yeah.
But she got a bed in a room.
I know. Well, there's a lot more rooms now.
And
They've doubled the size.
A little bunk kind of reeled out in the hallway.
Yeah. So, yep, patients get very good care there. So, so it's a family affair. So I trained And I've been in my primary care practices in Northbridge, Mass. Initially, it was at the old
The old Whitensville Hospital?
Yes, and now we've moved to a new building about 3 years ago. We've grown from a physician practice of 2 to a physician practice of 7. We have 6 physicians and 1 physician assistant in the group. Mm-hmm.
Now, is that from practical, I mean, when you hear the OB practice,
Mm-hmm.
first of all, you are rare because, okay, family and an OB.
So I trained in family medicine, and typically in many parts of the country, family medicine doctors do low-risk OB because there's a lack of OBGYN physicians in the area. We don't have that issue in Massachusetts, but because of our training, and I wanted to do OB in a community setting, and when I came to Milford, it was one of my deal breakers. So I said, either I want to do this or I'm not going to come here, I'll go somewhere else. And I have to say that Ed and at that time the former CEO, Frank Saba, were extremely supportive. And because of, and I would say that there were folks in the OBGYN department who were equally supportive because they had to back us up as low-risk providers. They had to be, if the patient needed a C-section, they needed to come in and help us. It was a really nice way to recruit other family physicians to the area. One of my favorite stories, and a patient still in my practice, is I was almost 9 months pregnant with my son, and it was 2 days before I was to go on leave, and I got called in to deliver one of my patients. So my son and her son are 2 days apart. I still see him in my practice as a family medicine doctor, and we laugh because I'll never forget his birthday because it was the last baby I delivered before I delivered my own. And we did OB as a collective group for about 7 years, and then there were some staffing issues, and some of the doctors decided for family reasons they wanted to stop practicing, and so ultimately, that was started at the beginning of the hospitalist movement, and we all kind of stepped back from OBGYN practice, but I do a lot of women's health in my practice, and I still see newborns, right from birth, the second they come out of the nursery.
Now, the OB side of it,
Mm-hmm.
you hear more and more how parts of the country can't find anybody.
Correct, yeah.
Part of it, is it still a financial nightmare?
And what do you mean by that?
Well, the malpractice and the burden they place on OBGYN docs.
Right. So I'm not an OBGYN, but I do think that is probably a barrier to getting folks to train to do OBGYN. And I do think that in some areas, you're fairly isolated, and a lot of physicians don't want to practice in that environment of being totally isolated. They like to be around other folks, and some physicians, if they don't want to be in a community setting, actually will opt for an academic medical center, which is hard to find in the middle of Wyoming. So geographically speaking, the larger states have much more of a problem. There may be one academic medical center that does high risk that'll attract OBGYNs, but surrounding communities won't have that opportunity to be able to support an OBGYN practice, so people travel far to see those specialists. We're lucky here. We have a great OBGYN department at Milford, and we're actively recruiting and growing as the communities around us grow.
Now, you mentioned low risk
Mm-hmm.
delivery.
Mm-hmm.
For an old man who has no clue, what does that mean, low risk? I guess that there's a high risk?
Yeah, so there's high risk and low risk. To break it down in easy to understand terms, low risk are, healthy young women who, don't have diabetes, are having regular prenatal care, don't have any other medical problems that would give them risk of pregnancy, so they're not diabetic, for example, and they, don't have substance use disorder. Anything that sort of could potentially harm the baby or make it more risky would be considered high risk. Family medicine physicians would participate in low risk patient care, and if the patient becomes high risk during the pregnancy, we would get our OBGYN colleagues involved in caring for them. from that point forward.
So now once they deliver,
Mm-hmm.
they hand off the baby to a pediatric practice, a generalist, what?
So it depends. I mean, there's a couple different models in our system. So when a woman delivers at Milford now, they have a choice of if they are, for example, in my practice, we're all family medicine doctors, so we care from people from birth to death. So if the mom of somebody is pregnant and they want to bring the baby to me, I always offer that I'm happy to be the pediatrician of record, even though I technically have a closed practice. I always take family members. So I have several families that have several generations in my practice. Sometimes we have a large pediatric group of physicians within Milford Regional System, and they will, depending on where they live, the nurses might recommend a specific practice. So you live in Franklin, Dr. Lyons, or you live in Mendon, Dr. Collins. So there's a lot of different referral patterns that they could do. And then we have a brand new Med Peds group, which is internal medicine pediatrics double-boarded doctors. There's a large group of them in Hopkinton right now that are all new and taking patients, and they will see infants as well right from the nursery. So we have several different options.
Well, it's got to be working because, when my daughter turned 26,
Mm-hmm.
the pediatric practice finally said, "You're a big person now. You must leave."
Mm-hmm.
And she had to pick a new physician.
Right.
Your name came at the top of the list as the best of the best to pick.
Well, that's nice.
And then there was that bad word, closed practice.
Yeah.
And I looked at her and said, "Well, what time does she open?"
Yeah.
To me it was, okay, if it's 5 o'clock, she's closed. What time does she open?
Mm-hmm.
Explain to the people open practices, closed practices.
So when physicians start in practice, we all take new patients, and often the best way to acquire a practice or build a practice is word of mouth. I don't think when I started 20 years ago that they did one iota of advertising for me. They didn't need to. The Blackstone Valley was a very physician shortage area, and so people just heard that I was in practice and started coming. There is a point where you reach a maximum ability to actively and effectively care for the group of patients that you have in a safe way. And that at that point you need to close your practice. Now, there's obviously, patients move and patients die, and so there is some turnover in the practice. But there's a set amount of patients that most physicians feel comfortable with, and depending on what type of practice you have, the numbers fluctuate as to what that is.
What kind of pool would be normal?
So for internal medicine doctors, and those are people taking care of just adults, generally around 1,500 to 1,600 patients is a full panel.
Wow.
Yeah. You were saying wow because you think that's a lot or a little?
That's a lot of people.
Right. And the more complicated and the older those folks and sicker.
Depending on the demographic. 'Cause
correct.
You get old men like me, we need a lot more attention.
Correct.
Or the young baby,
Right. So family medicine doctors tend to have more patients in their panel, somewhere around 1,800 to 2,000. And then pediatricians can often manage 2,400 patients in their panel. So, because kids are, in general, healthier and have less medical issues, so they can manage a larger population.
Seem that way? It seems like when the kids were growing up, I was running to the pediatric
I know.
office all the time. Is it just perception, or?
Well, I mean, because, seeing a sick guy for an ear infection that, you're worried about, and you see the pediatrician probably can diagnose that in a minute and give you medicine whereas somebody with multiple medical problems who's older just takes more time on
Rotundo men with diabetes and blood pressure.
Yeah,
Now you got to take
for example,
in all the pieces.
Just take a little more time to, sort out their problems and make sure they're getting adequate testing and care, whereas for the most part, kids are healthy and easier to manage a larger group.
Isn't it hard, though, to turn people away?
Yeah, so part of the issue is that, so although I'm closed, I'm going to say this and now probably regret this tomorrow.
Tomorrow when the phone rings?
Yeah, I take all family members without question. So if, you're my patient and your sister needed a new doctor, I would take her without any question. And we do that. It gets a little tricky because when you're closed, the insurers know that you're closed. So every time I make an exception and take a family member, somebody behind the scenes at my administrative office has to call the insurance company and let them know. So
Why?
Because the insurance companies say you're either open, meaning you take anybody that calls, or you're closed. There's no in between.
But why do they care? I'm sorry to be naive. But
Well, because they monitor how many patients are in their plan, essentially, and who, who's seeing whom, and what kind of doctor are they, and how good are they? They monitor us just like our patients monitor us, and just
so
like
you
we
get
monitor.
rated by the insurance companies?
Yeah. Mm-hmm.
See, I would think you get rated by Uncle Phil. If you said, okay, I got 600 patients, I'm closing my practice, then he'd get grumpy.
Right. Well, so yes, there's a part of that as well, but I think he's recognized over the years with the guidance of our physician leader group that not every physician practice looks the same. So 1,400 patients in one physician practice may be very full, whereas 1,800 patients in another physician practice may just be full or not quite full. So there is some flexibility there. And some of it's how the doctors practice medicine. Patients self-select the kind of physician they want. So I have more women in my practice. I have more patients with, mental health issues that like to use me as a therapist of some sort too. So I think that honestly, patients self-select. I have friends that go to physicians that are very matter of fact. They just tell it like it is. You're in, you're out, you're done. And patients figure out who does what, and they seek out
doesn't seem like any
the
fun.
patients they like. Well, you'd be surprised.
I have a new physician, Dr. Carlson, who's wonderful, but the one before would look at me and say, "You fat old man, you lose weight or you die." And I was like, okay, you got my attention. He knew exactly how to get, okay.
Yeah. So I think that works for some people.
Yeah.
Other
people may not like the direct
other people not
approach.
like that message. Yeah, I do have patients that tell me though that when they go to the drive-thru at Dunkin' Donuts, they see my face pop up before they order their donut. Because I yell at them so much not yell isn't the right word. I emphasize the need to control their diabetes better. So
Yes, it's my darling bride. I mean, every time it's like, no. And somehow she knows. After 100 years of marriage, it's like, she's gone. I'm going to go sit on the couch. The phone rings. So God forbid, I mean, I go to Dunkin' Donuts, I get my coffee.
It's black though.
It's black, and I salivate over the chocolate frosted. But like you say, now she'll know.
Mm-hmm. Right. Well, that's good that she keeps you in line, it sounds like.
After 100 years of marriage. But I'm told, when we got married, it was the first 100 that are tough. So I'm on the downhill.
You're on the
It's supposed to get
downslope.
easier and easier as we go.
I'll keep that in mind because I'm only at about number 24.
Oh, you're a newlywed.
I'm a newlywed.
24, you're a newlywed.
Yeah.
So now, when you look at the shortage of, I guess, primary care or family, is there a
Primary care.
difference?
So primary care includes family medicine, internal medicine, and med peds. We're all considered primary care, and pediatrics. Mm-hmm.
But you say you're a family medicine
Yeah.
doc.
Right.
How is that? How do you draw the line on primary care? Is there
So-
something they do differently than you, or?
No, we're all primary care. So this whole group of us, so internal medicine doctors, family medicine doctors, and pediatricians are all primary care trained. The difference is some internal medicine doctors go on to specialize. So your cardiologists, for example, train in internal medicine, and then they do a fellowship in cardiology. Your gastroenterologists train in internal medicine, and then they do a fellowship in gastroenterology.
I'm always amazed, especially with the mudfuds, the MD PhDs. It's like you're getting out of school when it's time to retire.
I know. I did go to, yeah, I had a classmate in medical school who was an MD, PhD, JD.
Oh, God almighty. I don't even know what to
she
call
ended up
those.
doing. Yeah.
I wouldn't even know what to call
I
her.
know.
I mean, the mudfuds, when we were down in NIH,
Yeah.
okay, they're mudfuds. They're MD, PhDs, who I guess never really wanted to go out and practice, patient. They didn't want to be clinicians.
Right.
They loved doing the research.
Mm-hmm. Yeah.
And thank God you got them.
Right. Absolutely. Although we may not have them for long if they take all the NIH funding away.
Oh, all these years, all I ever hear is they're going to defund NIH. And everybody rattles their swords, and the Beltway shuffle always happened.
Beltway shuffle. Yeah.
In the Beltway in Washington, because we lived right outside, when the Democrats were in, they hired everybody, and government grew. The Republicans came in, they cut government, so they hired them all outside the Beltway as consultants.
That's right.
So, when I think about primary research, it's just not profitable.
No.
You can't have a company trying to do fundamental research.
Yeah, basic science research, probably not.
There's going to be 20 years before they get a return.
Yeah.
They'll never see it.
Right.
So, when you think about it, used to be 85, 88% of research grants in the biomedical field were NIH based.
Yeah, not anymore.
You sit there and say, you can't take it all away, no matter what.
Right. You'd hope.
Well,
Yeah.
what are you going to do? Stop doing medical research in this country?
Well, no, they'll just privatize it and make it profitable.
But you can't privatize basic research.
I completely agree.
When you start thinking about the original work done in stem cells and all, how many decades?
Many.
Nobody's going to be able to commercialize some of these basic technologies.
Right.
Why don't people want to go into primary care as often as we'd like them to? Because Phil keeps saying that's his hardest role.
It's hard. So I think it's probably a multi-pronged answer, and I'll do my best to sort of look at it. I only have the retrospectoscope as perspective, so I went to medical school already thinking I was going to be a primary care doctor before I stepped foot in the door.
Really?
Yeah, I wrote my essay to get into medical school about the sound of my family doctor's car driving into my driveway when I was a kid and knowing I was going to get a shot of penicillin for whatever ailed me. And so I had always felt that that was my calling. I think I like relationships with people and I like problem solving, and the two together work well in primary care. Back when I started, I think the focus was so much on taking care of the patient. And we wrote notes and paper charts, and we, signed off on paper labs, and nobody was watching over my shoulder about, we used to joke, nobody died of a short note, okay? But things evolved, and the age of electronics met medicine, and I think the evolution of our electronic medical record and insurance company regulation, if I could tell you the amount of indirect work I do in a day, you would fall off your chair. If I have 20 patients booked as a primary care doctor, I am probably spending 4 extra hours per day doing some sort of indirect yet patient-related work, whether it's refilling a prescription that needs a prior authorization, which requires phone calls and papers and faxing, whether it's making sure that the patient who has diabetes has their medical labs done every quarter because their insurance company wants to make sure they're getting those lab tests every 4 months. It's good care. I would do it anyway, but they have a paper process that they ask us to participate in to make sure it happens. it's sometimes referring folks to other physicians that require letters and phone calls. So primary care, it's hard. It's not glamorous.
Now, wait a minute. 4 hours a day.
I'm going to say on average, 4 hours a day if you're seeing on average 20.
So that only leaves you 3 hours a day to see patients?
No. That 4 hours doesn't necessarily happen when I'm seeing patients. So, so again, primary care. I think most people who are successful, whether in medicine or not in medicine, work hard.
Yeah.
They go to
40-hour work week.
No, those are a thing of the past, and I think we all recognize that. I think as long as you're doing something that you feel has value, it makes sense. I think there are things that we as primary care doctors do that do not feel valuable, and they don't necessarily help us take better care of patients, but they help Medicare, CMS, monitor what we're doing. So a lot of things happen because the government needs to know data collection. And so it becomes a bit of a process to, if I could just go to work every day and take care of patients and write my notes and go home, I think, my happiness factor would be even higher than it is. I still love my job, but I do find there are some frustrating points.
But isn't that why they're adding so many mini physicians?
You mean extenders?
Yes.
Yeah, nurse practitioners.
Nurse practitioners. I mean, they seem to be taking on a lot of the routine role that physicians...
That's part of because we can't recruit doctors to do primary care. And honestly, they're a valuable part of the care team. I work with a PA who is wonderful, and she will often see patients on days that I'm not in the office when I'm doing my medical director administrative role. She'll see my patients. She'll help, if they need to go see a specialist, she'll help organize that. She'll follow up on lab work that she may order. So they are helpful, but just remember, they're still producing volume and work and indirect work. So even though they're part of the care team,
it still comes under your umbrella.
Still comes under my umbrella in some level. I have to supervise her. I have to do chart review with her. We have meetings regularly to discuss patient care. So it creates work. It helps patient care. It helps access, but it creates work. Yeah.
Because if I'm going in and I want to see Dr. Liz, and there's this not Dr. Liz, wouldn't that make me a little nervous saying, okay, why am I seeing the JV?
Yeah.
Can't I see the varsity squad?
So, you have a choice to say, I prefer to see the Dr. Siraco, and the answer will be, that's great. Melissa can see you today. Dr. Siraco can see you a week from Tuesday. So depending on what the issue is, patients say, okay, I'll wait. Or sometimes if it's significantly serious, my medical assistant will figure that out and find a spot for them that doesn't exist in my schedule, but she'll create one, and then I will see that patient as a squeeze-in. But yeah, but she's great. I mean, she's my right hand, and actually patients like her, they say, I see Melissa a lot, and I'm happy to see Melissa, but there are some things that they want to see their regular doctor for. And so we have that relationship.
But now you've got your family practitioner, you've got Dr. Liz, Mr. Liz, at the Taj, at the emergency room.
Yeah.
And you got urgent care in the middle.
Yes.
How does that play? Because, I can see the urgent care piece that, if my daughter sprained her ankle or something,
Yep.
I can't just call you and say, can you drop what you're doing and let me pop in?
Yep.
But I don't necessarily want to go see the other Dr. Siraco at $500 deductible. That's
why I usually I tell people, you hope you never have to meet him, but if you do, he'll take good care of you. So the urgent care is, I think, has an important role in patient access for patients in our community to avoid the emergency room. I think the key is to know what's truly okay to go to urgent care and what really shouldn't go to urgent care. And sometimes it's helpful for patients to call and check with their primary care doctor first, because sometimes we can tell either I might try to fit you in if you sprained your ankle and I can, or if I'm going to send you to urgent care and I'm pretty sure it's just a sprained ankle, I'll send you to urgent care. But if, it's a question of, ooh, could this be a blood clot in your leg and not a sprained ankle or something more serious, then I might say, really, I think you should either come here and let me tell you that before I send you to the emergency room, or go straight to the emergency room. So I think that patients need to understand that sometimes we have to make our best guess by the phone call to figure out where the best place for them to go is.
Well, you also know the person.
Correct.
And I mean, I can backfire, because I remember one time when my youngest was playing soccer, and she wasn't a complainer. She usually power through everything.
Mm-hmm.
She took a real bad hit,
mm-hmm.
and sat her down. And then as the game got tighter, she was like, I'm ready to go back in.
Mm-hmm.
Well, my darling bride is very forgiving, because I think for years she forgave me for putting her back in and finding out that she had a broken collarbone.
Oh, jeez.
Yeah, Sharon was out of town. She comes home the next day. She says, I just took your daughter to the emergency room. I said, why? Because she has a broken collarbone.
Okay, well, if it makes you feel better, I let my I let my son walk around with a broken arm for like 3 days because his sister kicked him in the arm when they were younger, and I was like, you're fine, you're fine, you're fine, Mother of the Year, right?
Yeah, there you go.
And then it was, 2 days before Christmas, and I was calling the ER saying, oh, I think Andrew might have broken his arm. So brought him in, and sure enough, he still likes to tell that story to his friends. Yeah, my mom, the doctor, let me walk around with a broken arm for 3 days.
Yeah, that would be great. As you're sitting at breakfast saying, honey, could you take him with you to work today?
I know. 2 days before Christmas, I thought the nurses were going to kill me, but it turned out fine.
So now, you talk about the electronic medical records.
Mm-hmm.
Phil is so proud of how much they've spent and how much they're going to spend on the new system.
On Epic. Mm-hmm.
On Epic. It's
Mm-hmm.
an epic investment.
Yes.
And I don't think people understand that this is measured in millions.
Oh, yeah. I mean, so the advantage of electronic medical record are vast. I mean, I can read all of my colleagues' notes, which back in the day when we were in paper charts, if you had bad writing, you couldn't read people's notes. And most recently, one of the general primary care docs in the Whitensville community retired, and we inherited his entire practice. And I had worked with him when I was in training in Worcester. And so as those paper charts were being put into the electronic medical record, I was like the go-to person. What does this sentence say? Because I could read the writing.
Was he writing in?
Yeah. So it's really nice to have a record where we can all read each other's, and we can communicate with each other. So if I'm on call on a weekend and one of my colleagues that I cover in Franklin's patient calls me, I can see their chart, which is really helpful. It helps me be a better diagnostician. It helps me take better care of the patient. And so that's really helpful. The downside is the amount of documentation that we have to do to create a note as part of the regulations that we're under.
But that investment alone seems, some of the primary care people I've talked to have said, I couldn't start my own practice.
No.
Just the investment in the
Correct.
Electronic medical records would drown me.
Yep. It's expensive.
Because I never understood. School I went to, Holy Cross, has a lot of people that go to med school.
Mm-hmm.
So a lot of my friends who graduated with me, they told me, okay, so you did 4 years, and then you went out and started earning money.
Right.
I did another 4 years, and another 2 years, and another 2 years. Today's money at 70 grand a year.
Mm-hmm.
And then I walk out, and let's see, I have to buy like a house to make my practice in, $300,000-400,000. Cost me $300,000 or more to outfit it. He's like, I'm 1-point-something million in debt, and I haven't gotten $1 yet in revenue.
Right. And so back in the day, you might be able to recoup your investment with seeing 40 patients a day or something in primary care, but that's just not feasible these days. I don't think patients, I don't think it's good care to see that many patients a day, and I don't think it does anyone any favors. I think the guys who did that back in the day are burnt out now and retired, and that didn't even count a electronic medical record, right? So it's just not a sustainable situation.
Now we've got a show coming up where Kate Burke's going to talk to us about burnout.
Oh, she is? Okay.
Because it seems like
I've heard that talk.
we keep hearing more and more, and this sounds terribly sexist, and I'll apologize, but it seems like women suffer more on the suicide burnout rate. Is that fact or fiction?
It's fact. So the statistics say that female physicians are 130% more likely to commit suicide than the general female population, and male physicians is high as well, but not that high.
Why?
I think it's a multifactorial answer again. I think that, so physicians, we tend to be overachieving, kind of perfectionist
Not the
type
slowest,
people.
laid-back people
Yeah,
that
right.
got through college
Yep.
with a 3.9 and had to then go to med school.
Right.
And yes, I can see that.
And so I think what happens is when you put yourself into a career that is emotionally exhausting, and you somehow lose the balance, you lose sort of the ability to step back and take care of yourself. And electronic medical records have also, and the invention of hospitalists, which have made our lives better but worse, right? So we're all siloed now. I can go through an entire week and not see another physician.
Really?
I mean, I sit next to one, but he's down the hall, and the other people in my practice are on the other side of the building. So unless I make an effort to walk over and see someone, I might not see them. So I think, the definition of burnout, which I know Dr. Burke will talk to you about, has to do with being emotionally exhausted and depersonalized and feeling undervalued. And I have to say that most primary care doctors, I think, have some feeling that they may not be as appreciated as they should be. I am lucky to say I don't feel that way. For the most part, my patients are wonderful to me, and we have a great relationship. But I think starting out new in primary care, patients have very, very high demands. They think that doctors should be available to them for the most part 24/7, which is very unrealistic. It can create some adversarial, I think, or unrealistic expectations. And so physicians don't want to disappoint, so they work. And that can lead to burnout.
See, I thought the whole concept of hospitalists, I remember when my number 2 ungrateful offspring was coming into the world, we warned Dr. Bellucci. I said, number 1 came in 2.5 hours. When they light the fuse, it's going to be quick. And it was 45 minutes. And he actually, to his credit, the minute we said it was midnight, it was 2 minutes to midnight. They made us wait till after midnight so we didn't get in the insurance game. Thank God they told us.
Yeah.
Well, as soon as we called him and said, she's here, he was there within 15 minutes. Because I remember the guy sleeping in the next room. And it was like 45 minutes later, 10 centimeters, we're there.
Oh my goodness, yeah.
But it seems like a heck of a burden to place, because he's got a family. He's almost got a life.
So we know what we sign up for.
Yeah.
So I would say that, as physicians, when we enter medical school and we do residency, we know what we're signing up for. It's part of our job. I think what the students and residents coming out of school now do know is that electronics and regulation are here to stay. And so they've adjusted their work-life balance to accommodate the extra stressors and structure that's on them versus folks like me who kind of, I knew what I was signing up for. I was going to be on call every third night, and I was going to be called into the hospital in the middle of the night, and I would have to go to the ER. This is before hospitalists. And I knew that. And then when hospitalists came, I thought, okay, so in order to give my patients better care, I'm going to work till 8 o'clock at night, and I'm going to start at 7:30 or 7:45 in the morning, just to give them better access, not every day, but most days. So that's something that we adapted to, and we felt it was part of our job. And I think that some of that is changing as time evolves.
That could have been funny. I could see going into the emergency room, saying, I want to see Dr. Siraco. And your husband shows up. I say, no, the real Dr. Siraco. He probably would have taken less kindly to...
Yeah, so my patients do hear him being overhead paged when they're in the emergency room, and they're like, is she here? And if he knows he's seeing one of my patients, sometimes he's like, yeah, I don't usually introduce myself. He takes his name. I know. It's good. Neither of my kids are going to go into medicine, though. I'll just tell you. Yeah.
Really?
Yeah. My daughter's going to be a school teacher, an elementary education major, and her hope is to be a third grade teacher. And my son is starting college in the fall at University of Texas in Austin, so really close to home.
I was going to say Virginia and Texas.
I know. You'd think they don't like us.
I had both in Worcester.
Well, that's
and
nice.
it made life easy because, we were on campus twice a week.
Yeah.
And you only got to see him for 10 minutes. It's like you walk over, you get your kid fix.
Yeah, and then you leave.
And then you sit back. She was cheering. So we could say we were with her for 2 hours.
There you go.
No, we were with her for 10 minutes, but I got my kid fixed.
Right.
Texas.
Yeah, so it's a very, very good civil engineering architecture program, so that's what he's going to do. So he's following in his grandfather's footsteps.
You couldn't push him to a little school like MIT or something that's within driving distance?
No, he wanted big and far away and south where it's warm.
Well, we started down that road where my oldest, everybody told me, don't influence. So she started College of Pluto, University of Mars. How far can I get away from Milford as the center of the universe? And then slowly but surely, the circles came back, and she ended up going in Worcester. Of course, my little one, she said, I'm going to Holy Cross. It's the only place I'm applying.
Wow.
Scared the living...
She was confident.
Oh, God, was she ever, but it scared the living heck out of us that she said, no, that's where I'm going.
Okay.
It was the longest 3 days of our life from when she put her application in.
Yeah, I bet. 3 days?
3 days.
That's all it took?
It was a terrible week. She put her application in on the Tuesday when they got their grades. She didn't get the phone call till Friday morning. So that whole week we're like, what's going to happen? We're going to have to teach her to say, do you want fries with that order?
Oh, no.
So now, besides mother of 2 children, having a family practice, you get home and you say, I'm bored. I want to take on another role as medical director.
Yeah, just because I didn't have enough going on.
I was going to say.
Yeah. So this is sort of strategic in that I'm going to be an empty nester next year. So, maybe there's a little bit of that. But
oh, don't look forward to that.
So, no, I'm not. That's why I want to work a lot.
It took me 6 months when I took my oldest to Clark. So you're all psyched. The adrenaline's there. You move her in. Then I drove home, and I looked at her room, and there was this black hole. For 6 months, my darling bride and I argued, because every time we walked by, I'd close the door.
Oh, and shoot.
And she'd open it. Says, you don't have to. I said, yeah, it's not the same.
I know. I know.
But then you get lucky, because then both of them moved back in.
Yeah.
So that was okay.
That's good. Yeah. So medical director is something that, it's a learning opportunity for me to learn sort of the other side of medicine, the non-patient care side of medicine. And Phil likes to joke that I've eyes wide open. I've seen like a part of, it takes quite a bit to run a medical group and a business, and there's a lot of projects that are ongoing, not the least of which is developing a new building. And we're part of the Partners Healthcare network, so some of my work has to do with maintaining our quality index in our RSO, and Traditionally, Milford Regional has been the #1 quality RSO in the group, so we've scored very well in all the benchmarks. In fact, partners came to us and said, you should join us because you guys are a bunch of really good primary care doctors. And so it's been a good marriage, so to speak, that we've gotten, programmatic expertise for them. We have some initiatives with different programs, behavioral health programs that they're helping us implement in our group, along with, we just had a meeting recently with substance use disorder folks from the Mass General, with myself and Dr. Hopkins in the emergency room, because there's so much substance use disorder in the Milford area that we...
All we hear about is the opioid problem.
So we have wanted to team up and figure out the best way to tackle this. Harm reduction is clearly the way to go. So whether it's police having Narcan, our offices all have Narcan. I give Narcan to any parent of somebody who tells me their kid's addicted. Harm reduction.
So you have to have respiratory inhibitor, you have to have Narcan in your practice?
We don't have to, but we've all chosen to.
Well, but I mean, really.
Yeah, there was an incident a couple years ago, actually, in our office where somebody drove up and left a patient who was in respiratory distress in the lobby of our office and ran away. And so luckily the EMS folks came in time, and that was before we had Narcan, and so then we instituted the policy to have that in the office. And so we have it in every office.
It's amazing because, when you look at the opioids, they're really effective at being a respiratory inhibitor. They do their job very well.
They do.
They may get you high along the way, but their job in the world is to stop you from breathing.
Well, it's actually to stop the pain that you might be experiencing. But the most fatal side effect is that it inhibits your ability to
breathe.
Yes. And so, and unfortunately, there's so much abuse potential with it that people don't think about that side effect when they're abusing the medication. So, there's a difference between dependence and addiction. Folks who take opioids post-surgery and have a lot of complications post-surgery and continue to need narcotic medicines become dependent physically on them, but they take them as prescribed by their doctor, and they don't overtake them, and they don't abuse them, and they're taking them the way they should, but they're still dependent. Folks that are addicted tend to use them in ways that are not as prescribed and try to take more than prescribed or divert medicines in a different way to abuse them. So there's a difference between dependence and addiction. And they both have their own issues, but I think we're trying to focus our initiatives on helping people who are truly addicted get help.
Well, it's funny because we've had Amy Leone and a lot of people on the show,
yeah.
And you talk about when we grew up, you thought of a heroin addict as kind of a sketchy person, slimy, sitting in a dark alley in Boston. And all of a sudden, today, you look and say, it could be my neighbor's daughter who hurt her knee.
Right.
I remember when I tore my ACL and I got pain meds. I'm not filling it because my wife kept saying, why aren't you filling your prescription? I said, nope. I don't know, but unless I really need it. And it was miserable. But I was scared to death that, I'd be one of those statistics that without knowing would fall, I mean, it's bad enough. Alkaloids are my friend. I like caffeine.
You like caffeine.
I like caffeine. I know I am addicted to alkaloids.
Me too.
So, I sit there and say, if I could be I'm not taking opioid chance.
Right. I think the key to thinking about this problem, which is certainly a crisis, is to think about how we can help patients destigmatize the illness, treat it as an illness, and understand that substance use disorder, whether it's alcohol or opioid or, cocaine or any substance, is generally a pediatric problem. Very few patients pick up their first substance as grown adults.
Really?
Really. If you talk to folks that are in recovery, most of them will tell you that they probably got high at 10 or 11 or picked up their first drink early on.
Wow.
And there's been, part of that is the argument why we should raise the tobacco age to 21. It's because really, if you're 21 and you're buying cigarettes for a 16-year-old,
Wow.
there's something wrong there. But 18-year-olds can hang out with 16-year-olds. It's much easier to bum a cigarette off your 18-year-old friend than it is your 21-year-old friend.
The whole tobacco. I'll admit I'm still a smoker. Once every 3 or 4 months, I have a nice cigar.
Okay.
And a friend of mine, we were over his house, and he said, "How long?" I said, "It's been about 3 or 4 months." He goes, "Time to go have a cigar." We snuck down the street. We kept looking over our.
You're right.
You think they can see us?
You're right.
No. And I said, we're going to risk getting arrested because some young millennial's going to look out their window and see 2 old men sitting on the curb
smoking a cigar
and call the police. It's going to be bad enough that we get busted by our kids for having a cigar.
Right.
But how do I explain I got arrested?
I know. I got arrested for smoking a cigar.
You think about it. When I grew up, having a cigar was not, you do it, not every 3-4 months.
Right.
But a lot more frequently. Now, I guess the guilt, the knowledge.
Some of it's probably, the knowledge. I think that it's, I think there's still like a cult following in college that a lot of college guys smoke cigars, which is just gross. But no offense. But I think that, nicotine is the second most addicting substance behind heroin. So
is it really?
On the brain. That's why it's so hard to quit. People tell me it's much easier to stop drinking than it is to stop smoking nicotine.
Wow.
So the goal would be to never pick it up because once you pick it up, the chances of you being addicted are high. And it kills a lot of people, just not in the way heroin does. Heroin's on the front page because it's killing people in a, very dramatic way. But
it's funny, it's probably more of a social thing because I'm thinking back right now. It was Christmas when we had our last cigar.
Yeah, so you do it.
So,
around
now
the
it's
holidays.
5 months.
Yeah.
Have
and
gone
you haven't
by.
had another cigar.
I haven't done another cigar.
So I would say that you're not addicted to cigars.
I don't think so. But, it's you get old friends and we sit around and, that was...
Yeah. And you also have an adult brain, so nicotine on your brain is very different than nicotine on a 16-year-old brain. So that's what we want to avoid.
Well, the scariest part is, like you say, you don't want to develop a habit.
No.
That, you start smoking or, God forbid, you start smoking cigarettes.
Right.
But even that seems to have gone, you can't stay in a hotel. It used to be, when I was growing up, or I had to ask for a non-smoking room.
Yeah.
Now, it's not even an option.
No.
Which is good.
Good. Yeah.
Maybe after this generation, we'll hit that wonderful goal of smoke-free.
Yes, that would be nice. Yeah.
So, medical director. What did you hope to accomplish as the medical director?
So when I applied for the position, I had a bit of a vision, and it's kind of morphed into a little bit of a different vision. One of my goals was to make sure that we were taking care of our physicians in relation to burnout. So making sure that the docs in our group felt that they knew they could come to me and discuss clinical problems or symptoms of burnout. I'm working on becoming more skilled in having difficult conversations with the doctors that I think are suffering from burnout and need some help and guidance. We're in the process of applying for a grant to restore the joy to medicine, which our physician lead group met and discussed today. So there's some of those initiatives, and I also hope to make sure all the partners programs that we're implementing, that we maintain our #1 status as a quality RSO.
But as you help the
And
physicians and recruit,
And
but
recruit
as you
primary
help
care
the
doctors.
physicians, you're also helping the patients.
Correct.
Because I remember reading, these residents way back when you had to be on call, or it was like 4 days in a row, so you're on 80 hours. I don't know if it's fact or fiction, but I really don't want somebody who's been working for 80 straight hours
I know.
making a decision that can affect my health.
Mm-hmm. Yeah.
So whether they're burning out or not,
Right.
I'm nervous.
Yeah. So I think, there's some mindfulness, and physician wellness is one of the goals that I have. I also think education. I've been doing a quarterly newsletter. We took antibiotics as the first topic because there's so much antibiotic resistance in Milford, and we really need to be more stewards of antibiotic use and not be prescribing antibiotics because the patient thinks they need them.
Well, they've read it on the internet.
Yeah. So, and it does take longer to educate somebody about why they don't need antibiotics than it does to give them a prescription. So that's one of my short-term goals, and we've done pretty well on doing some of the initiatives in terms of our antibiotic stewardship program, so it's been somewhat successful. I also did something last year on tick-borne illnesses, which is going to be another big...
With Michael.
Yeah, another big problem this summer. Yeah, he was wonderful helping me put together the newsletter that, all the primary care doctors can use as a reference
He's
tool.
one of those physicians I always get a kick out of because he's so quiet and laid back until you get him to talk about the disease state.
Yeah.
And then just stand back because you can see the passion and
Yeah.
the knowledge just...
He's very smart, yeah. So he's a good resource for all of us as well.
And he has a daughter that went to Holy Cross. He gets 2 points.
So my best friend from college went to Holy Cross.
See?
Okay. My medical school, sorry, because I didn't go to Holy Cross. My best friend from medical school went to Holy Cross as an undergrad. Yeah.
Cool. Thank you.
Thank you.
As always, it's amazing not only the caliber of medicine practiced at the center of the universe here, but also the people. When I talk about compliance being enhanced, you can't really explain, unless you've lived through it like I did with my mom, how important it was that she had the same physician, the same oncologist, that she could call by her first name the whole time, that she wasn't scared. So, as always, get to know what's available here, and you won't be disappointed. And tonight, you learned why, when my daughter was looking for a family practitioner, your name was the absolute first one on everybody's list.
Thanks.
So thank you for taking
Thank you.
care of my daughter.
You're welcome.
Thank you to the 6 loyal viewers watching. May God bless, and may tomorrow be a better day than tonight. Good night.
Not too long since I've been